Hello, welcome. This is Here's to Your Good Health. My name is Linda Prezioso. I'm a nurse practitioner at Family Medical Center and the owner of the Essential Health Medi-Spa. Tonight we have Dr. Choufani with us. He's a hematologist and an oncologist. And I'm very excited because unfortunately cancer is on the rise, and so we just want to talk to you about it. We want to talk to you about prevention. We want to talk to you about how you can stay as healthy as you can be. You know, that's the whole goal of this show, is to give you information to keep you healthy. So, Dr. Choufani, thanks for coming.
Thank you. Thanks for having me.
Good to meet you. It's
Appreciate
good to
it.
have you here.
Nice meeting you.
So, tell me a little bit about yourself. You've been where you grew up, where you went to school.
Well, that will take the whole time.
Oh, no.
I'm not young anymore. But anyway, I grew overseas in Lebanon, Beirut. In fact.
Okay, all right.
But when I completed my medical school, I came to Boston. And I did my training in internal medicine at Boston University Medical Center and my fellowship in hematology oncology at BU. And for the last, many years I've been practicing as a medical oncologist and hematologist in different setting, different hospital, different program, and really enjoying that field.
And so do you have a private office as well as the hospital, or only hospital work?
So no, I'm part of a UNC physician network at my workplace at the UNC Nash Cancer Center here in Rocky Mount, the Danny Talbot Cancer Center, and I've been there for almost now 3 years. As I said, practicing general hemoc, so general oncology, hematology at the community here in Rocky Mount and the surrounding counties.
Right. So how long have you been here in Rocky Mount?
3 years.
3 years?
Yeah.
Well, how come I haven't heard of you?
I'm still new here.
And fortunately, I don't have a whole lot of cancer patients. I mean,
which is good.
Yes, when that diagnosis is made, they kind of veer off of my path and move on over to oncology and get the treatment that they need.
And I think the purpose of all this event today is just how we want to keep that number low and minimize that cancer patient growing in number. Unfortunately, a lot of not so good news, but at the same time, a lot of good news in cancer prevention and cancer screening and improvement of treatment overall.
That's right. So we can talk about screening. I talked about smokers. Still got smokers. People still smoke. I don't get it, but they do, and so you got to treat them accordingly.
Yeah.
And so the low-dose CAT scan once a year is paid for by insurance.
True.
And so that's a good thing.
It's an excellent thing. Just one really small fact here: the low-dose screening CT scan of the chest reduced mortality by 20%.
Really?
Yes, by 20%.
That's a lot.
So years ago, before around 20 years or even more, when we didn't have the CT screening of lung cancer, 80%, 85% of all lung cancer presented to us at the late stage of the disease, where the cure rate is very low, and people who unfortunately die from the disease. Now is with the CT scan of screening of lung cancer, we're catching these cancer at an earlier stage, where the chance of curing is much higher. We have better treatment now than we did 20 years ago. A better side effect of the treatment, and in fact, overall, much cheaper taking care of cancer in early stage, cheaper for the patient, cheaper for the system as a whole, is much cheaper to treat an early stage cancer by removing the cancer than treating stage 4 for a long time, and then we know the outcome, and much higher price.
So just briefly tell our audience, is it 4 or 5 stages in cancer?
4 stages.
4 stages.
4 stages.
5 in kidney.
4 stages. So the purpose of the lung cancer screening, or any cancer in fact, is to catch or detect the cancer at an earlier stage. And the reason why, before symptoms occur or happen basically. And the main reason why, when we detect the cancer at an earlier stage, which is stage 1 and 2, mainly, then the chance of cure much higher, the risk of mortality, morbidity is much lower, and people are living much longer when the lung cancer is detected early, basically. And that's the whole purpose of lung cancer screening and any other cancer, basically.
Right.
And I think things change over the years. Now with this one, as I said, that mortality is reduced by 20% by just doing the CT scan, which is offered to an individual who have history of smoking. And I'll give you just more specific numbers. So if someone who have smoked for 20 years, 1 pack per day, then we call a history of 20 pack years,
Yes.
Made them eligible to have a CT scan screening. So anyone who smoked for 20 years, 1 pack per day, they can get a screening on a yearly basis, paid by the insurance, and it's a one-time deal per year, basically. As I said, the evidence, the data showing that the mortality has been reduced by 20% by just doing the CT scan, which is huge. Why is a big number here?
20% is a great big number.
20% is a big number, but
Yeah.
also just keep in mind that lung cancer is one of the most common, if not the most common, cancer that we detect every year. The good news in a way that this is totally preventable if people try or attempt to quit smoking. Because as we know, smoking is the number one risk factor for lung cancer, but also not only for lung cancer, but many other types of cancers. Stomach cancer, pancreatic cancer, bladder, head and neck cancer, quite common, unfortunately. So really, smoking, if someone really wanna just improve their chances or reduce their risk of getting many of these cancers, is try to attempt to quit smoking.
Absolutely.
I mean, that's really the
Yeah.
name of the game, to be
Yeah.
honest.
It's a tough thing.
It's not easy.
No.
It's not
no.
easy.
People have a hard time.
But I think trying is really worth. And now there is a lot of help through smoking cessation program, primary care clinic, supporting patient individual
That's right.
who would like to quit.
That's right. You're
Absolutely.
exactly right. So one of the toughest cancers in my memory is ovarian cancer.
True.
Is there any preventative measures for
Yeah.
ovarian cancer?
True. As far as screening and prevention, unfortunately, there is no really screening test that's approved yet by Oncology Society as far as detecting ovarian cancer in an early stage. Now, we talked about screening through a cancer marker in ovarian cancer, a tumor marker called CA125. We talked about pelvic ultrasound, but there is nothing yet confirmed or approved as a standard of care as prevention of ovarian cancer.
Right.
And that's really, but again, medicine change on a yearly basis. New guidelines come
That's
on a
right.
yearly basis.
That's right.
And I'm sure a lot of researchers and scientists are looking hard to find the screening tool for ovarian cancer and other type of cancers
Right.
too. Other type of cancer.
So we talked between us
Yeah.
about colonoscopy,
Yes.
colon cancer, which is
Yeah.
on the rise,
Yes.
unfortunately, and rising in younger people.
True, true.
So, and the guidelines moved from screening at 50 back to 45.
True.
And they've got now Cologuard, which I have found to be a very effective
Very
tool.
effective. Absolutely.
And
Absolutely.
insurance is very happy to pay for that as well.
They do. They do. And I think it's a win-win for everyone.
Sure.
People get detected earlier with colon cancer. They are cured at a higher rate, less morbidity, mortality, and it's a win for the insurance people. Then, as I said, it's much cheaper to take care of an early stage
Right.
colon cancer
Right.
by surgery instead of paying for the next 2-3 years treatment that's very costly, as you know, any cancer treatment. As you said, Linda, that it's true that younger people now are having colon cancer. A lot of reasons. We don't know. There is no really one risk factors. Family history is important. Some of the colon disease, like inflammatory bowel disease,
Right.
it's one cause. Small percentage of people and family members have what we call hereditary colon cancer, like Lynch syndrome or FAP. A very small number, fortunately, but these specific patients are higher increased risk of colon cancer because they have a higher number of precancerous lesion
Right.
found called adenoma.
That's
Or
right.
polyps. People know more about polyps.
Right.
Sometimes in the 50s, hundreds for these patients.
Really? That
Yes,
many?
yeah, absolutely.
wow.
Even hundreds. So,
Wow.
So as I said, fortunately, it's small percentage,
Right,
but
right.
it's there.
Sure.
Family risk, of course, if someone has a family history, brothers, sisters, mom, dad, first cousin, second, the risk is a little bit higher. But also, the other thing that we talked about preventable is, and this is very confirmed, lifestyle.
Yes.
So lifestyle about diet, weight control, fat diet, red meat, all the stuff that people like usually, but
Yes.
unfortunately put them at higher risk. So really, some of the now it's true it's younger people, but as you said, society is now recommending screening colonoscopy at an earlier age, 50,
Right.
45 instead
right.
of 50. So hopefully with this, the detection rate will improve. Now, the challenge here is to convince more people
Yes.
to get the screening colonoscopy.
Yes.
You mentioned the colonoscopy, but there is other tools
Right.
for screening, Cologuard, as you
Yes.
mentioned, which is an approved screening test, which detect, an abnormal DNAs in
That's
the
right.
stool specimen,
right.
and then by that, but that Cologuard is by itself is not enough. So
Right,
if it's
exactly.
if it's an abnormal test, we'll have to go
You have
the
to.
second step,
That's
which
right.
is the colonoscopy,
Right.
which remains the gold standard
Right.
of screening for
That's right.
colon
That's
cancer.
right. But the nice thing is, if you've got a positive Cologuard,
Yes.
then the insurance is going to go ahead and pay for the colonoscopy, and the GIs are going to take them in
Yes.
because of that. So,
True.
So
True.
that, that's kind of my ace in the hole for my folks.
Well, that's one thing. The same what happened when we had before the lung cancer, we didn't have any screening tool, but when we had the CT, low dose CT scan done on thousands and studied and approved, then insurance people had to cover for that.
Right, right.
So as I said, medicine is not firm, it's
That's
not
right.
rigid,
No.
change every year.
That's
Depends
right.
on the
That's
research
right.
that's been done.
Yep. It's not
And
black
as you
and
know,
white.
true. And as you know, in cancer field, a lot of research done on a yearly basis, for the simple reason because cancer, in fact, is one of the leading cause of death, second only to heart disease. So it really is a big
Yes,
public health
yes,
problem,
yes,
challenge.
Yes, yes, yes. So mammograms, of course, have been around, and they keep improving. They're now
True.
to 3D, which is, I think that's what NASH does. And
True.
So I would hope that breast cancer, the rates have decreased. I don't know if they have or not.
Yeah, the rates have decreased, no doubt. And that's why, in fact, a lot of women are who undergo screening mammogram are detected earlier and they're
Right,
cured.
right.
And let me just one fact about not only breast cancer but colon cancer. So if an individual are diagnosed with an early stage due to screening, early stage breast cancer or colon cancer, their survival at 5 years is 100%.
Really?
100%.
Wow.
Just doing the screening tool, which is great.
Right, right.
Versus comparing to if people, a lot of people unfortunately don't do screening, and then the cancer is caught at a later stage, stage 3 or 4, where the survival rate at 5 years dropped from 100% to around 30 or 40%. It's a big difference.
Yeah.
You could be 50-year-old, you could be 60-year-old, you could be 90-year-old. 60%, that's still huge.
Right.
Nobody wants to die earlier if they don't need
That's
to.
right. We
Well, I
all
mean,
want to
this-
stay
that's-
here.
Yeah, well, that's what it is. But again, I think the big challenge, you're right, for breast cancer is detected much earlier. Because as you know, over the years, the group supporting breast cancer will have been quite really influential and
Right.
doing good work.
Right.
And then
Right.
I can really, based on the experience, and even though screening breasts have been there forever, unfortunately, we're still seeing many women, young women too, coming later stage of the cancer for many reasons. I can name some of them. A lot of people and women too have fear of cancer. You know, people are
Yes.
scared.
Yes.
Even with screening, but they're scared too. Second thing is sometimes accessibility to these tests is not easy. People are working. They can't even find sometimes free time to go to screen.
Right.
I mean, really think about it. You know, people who have full-time job, it's always hard. As I said, accessibility. Some financial issues too, concern for a lot
Sure,
of people.
sure.
So it's still, definitely still have a lot of work we really need to do to get to a point where we could really benefit from these screening tools,
Right.
no doubt.
Right. Right.
Talking about NASH, you know, as you know, we have very strong breast center at NASH. As you know, UNC NASH Cancer Center, we have strong support from a breast surgery group. We have strong support from radiation oncologists. We are a 5 medical oncologist team at NASH. We have strong supportive team, a pharmacy team, infusion nurses team, financial team,
Right, right.
patient navigator, palliative care, really very strong established breast cancer
Right.
center at Rocky Mount in NASH, basically. And we see a lot of women coming from different counties, NASH, HCOM,
right,
but
right.
also the surrounding counties to NASH. I think, to be honest, we're doing a good job there.
Oh, I think so. I
Absolutely.
think so. I have had the opportunity for several years in a row to go. They have a cancer support group that meets once a month.
And they still meet.
Yes.
They still meet?
And I've been able to go and speak a few times.
True.
And I tell you what, those women
Yeah,
and men,
yeah,
mostly women,
yeah.
they are so strong. They are my heroes.
Yeah.
I mean, the stories they tell and how they got through it is just amazing.
And they still meet on a regular
Yep,
basis.
yep.
I think they're doing a great job providing support for all new breast cancer patients. People love them, there's no doubt. We're trying to establish different support group for other cancers too.
Right.
But really, they are really an example of just compassion to the
Right.
patients. Absolutely.
Right. So is there any other screening for prostate cancer? I know, of course, the exam
Yeah.
and the PSA. Does that seem to be effective enough for?
Yeah, it has been effective. Now, as you know, there is, like other cancers, there is some specific select people who may be at a little bit higher risk.
Sure.
And I wanna mention that because this is very important for our viewers and the population in the surrounding
Right.
area. As we all know that prostate cancer is much higher in many ways in the African
That's right.
American man.
Yep, yep.
Much more, not only the incidence rate is higher, but also prostate cancer in African American men are more aggressive. So I think we are really focusing and targeting African American man by doing PSA
Right,
screening.
right.
especially if now including white and African American, a man who have a family history of prostate cancer, father, brother, especially at a younger age, 65. Then we start screening at an earlier age, ideally around 45. So two things here is African American population, man,
Right.
And white man with risk factors. Also, as you know, a lot of our men at certain age, you know, a lot of them are veterans.
Sure.
And in the past, there was exposure to some toxic things, and that put them at higher risk. But again, screening is important. Screening is still available for prostate cancer individual. And please, again, at any time, if you have a question, concern, reach out to your primary care.
Absolutely. That would be me. Call me. I'll talk to you.
Primary care physicians, mid-level providers have really crucial job in helping the population in the community.
Right.
By identifying people who are eligible for screening, discussing the screening tools, coordinating with specialists if you need to, and you know, taking care of some other social or financial burdens if we need
Right,
to.
right.
So please just talk to your
That's
primary
right.
care.
That's right. Do that.
They do extremely good job, especially in screening and prevention.
We try, I can tell you that. All right, it's time for our first break. So when we come back, we've got more to talk to Dr. Choufani about. I find it pretty interesting. I hope you do too. Don't go away. We'll be right back after a word from our sponsors. Hang on.
About his patients. I told him, you were my guardian angel. My experience with NASH was A+. So then the surgery I need here on out, give me a blank piece of paper, I'll sign it. I want you to do it.
Learn more at nashsurgery.com.
We're in our 18th year of practice at the Hammer Chiropractic Center, and we've seen over 15,000 different people in the Rocky Mount area. 40% of headaches actually come from a neck problem. Many patients come in taking multiple aspirin, over-the-counter medications and such a day, and we can get you to stop doing that and actually fix the problem so the headaches don't rise anymore. A lot of people think chiropractic hurts. It does not. Most of the people come in and they feel great when they leave.
When faced with special care needs for elderly or disabled loved ones, families want compassionate, comforting care. That's Tender Touch Home Care Services' goal, providing the level of care we would expect for our own. With over 10 years of home care excellence, Tender Touch provides an array of services that keeps your loved one at home. From personal care, light housekeeping, errands, and meal preparation, to our private duty care program, which combines all of our home care offerings in one package.
Tender Touch Home Care Services, where your needs are our concern.
Hello, welcome back. This is Here's to Your Good Health. My name is Linda Prezioso. We've got a medical oncologist and hematologist tonight by the name of Dr. Choufani. He works at the UNC Cancer Care or the Cancer Care at Nash. I'm not sure, I guess those terms are interchangeable probably. But anyway, he's been with our community for 3 years, and we're blessed to have such a smart man, and he is focused on prevention. So we're going to keep on talking about preventative care for right now. And we talked about breast cancer, but we didn't talk about all the risk factors.
True.
So let's talk about that for a little bit.
Absolutely, absolutely. So breast cancer, as other cancers that we mentioned, definitely there's a lot of risk factor there. And a lot of them are really preventable. So there is some risk factors that are fixed that we cannot do that much. Of course, being female.
Yeah, well, we can't do much about that, that's right.
So age also is
factor.
of course is a factor. Some of the other stuff is prior radiation exposure, and fortunately not that common. But I'll give you an example. Many women at the younger age, in their 20s, 30s, they get sometimes a type of cancer called Hodgkin lymphoma or lymphoma or other therapy, for which they get basically radiation therapy to the chest area. So they put them a little bit at higher risk.
Oh, okay, I didn't realize that.
Yeah. Family history is very important. As you know, every time you go to your primary care or they keep asking you about what's your family risk. Do you have any sister or cousin or mom or grandma who have breast cancer? So family is definitely is a risk factor. Age, of course, you get older, the risk goes a little bit higher. Some of the also in regard to family history is the now that we're detecting more is genetic mutation.
Right.
One of the most common that I think a lot of people know, it's what we call BRCA or BRCA mutation. Unfortunately, they put women at much higher risk of having breast cancer. And so when we meet the new breast cancer patient at a younger age, so less than 50 or less than 60, if they have specific features, we order genetic testing. One of them, the most common, is the BRCA mutation. And the BRCA mutation not only affect the individual themselves, it will affect the family too.
Sure,
Because if they have a positive mutation, that will have to test other family members.
that's right.
The good thing in this, in a way, I mean, if you want to look at it as a positive thing, is that if you're aware of that mutation, you could undergo surgical prophylactic surgery
Right.
to prevent breast
That's
cancer,
right.
which is a mastectomy in most of the cases. So this is important. So these are the most common. So age, family, genetic, basically exposure to radiation. Some of the, to be honest, same as apply to other cancers, are lifestyle.
Yes.
Very important.
Yes.
Weight issues or obesity. We talked about, of course, smoking,
Right.
alcohol,
Right.
diet control,
Right.
exercise,
Right.
all this. So this is for breast cancer. So one of the things also that's coming now new is when women go for a screening mammogram, and probably many of you heard about that, what we call dense breast or density on a mammogram. It turns out this is a new one of the risk factors also too.
Dense breast?
Yes,
Okay,
on a mammogram.
I didn't realize that.
Yes, so
Okay.
this is now one of the newest risk factors. Again, these few risk factors we mentioned about, some of them definitely we cannot change but the other stuff that we talked about, exercise, smoking, healthy
Eating.
diet,
Don't drink very much
definitely
alcohol.
preventable and modifiable.
Right, right.
So just keep in mind.
And, well, anybody who watches this show knows, I preach every week, eat fresh, eat whole foods.
Absolutely.
Eat real foods.
Yes.
Stay away from fast food, stay away from processed foods.
Yeah,
And
I
we
mean-
all grab a burger every once in a while, and that's not gonna change.
Which is fine. I mean, look, sometimes, these things you still enjoy.
That's
You can't
right.
ignore that.
That's right.
But at least keep in mind, be moderate in
Right,
all this stuff.
exactly, exactly.
Keep trying. I think that's the whole point.
I cook so much.
Which is good, healthy.
It's healthy.
A little bit cheaper
Sometime-
now, I guess.
It probably is, yeah. Sometimes it's like, somebody said, "You like to cook?" Not really, but I like to be healthy. I'm going to eat healthy food.
So let me just, going back, since we're talking about screening and prevention, if we look at the cancer causes, the risk factor we talked about, 50% of these risk factors, so it's smoking
Yes,
and weight problem. 50% exactly.
that's a big percentage.
Serious, yeah, and these both are modifiable preventable.
Yes, yes.
The other stuff we talked about, family history,
You can't change
exercise,
that.
alcohol,
Right.
viruses,
Right.
pollution, all this stuff, it's there. So what I'm saying is most of these risk factors are preventable. And this is serious why you can reduce getting any type of cancer by just doing that. It's not easy to, it's easy to maybe talk about it. It's not easy, but you know what's the best way to do it. I mean, it will take some effort and some strong will to do that.
But we can do it.
Of course you
People
can.
have got to make up their mind, though. They've got to make up their mind that they want to be
True.
healthy.
True.
They want to make up their mind that I'm going to do the best I can do.
Absolutely. Look, I mean, we've been talking about smoking for how many years? But things are better now.
They are.
no doubt.
Yes, they are.
But still a major problem.
It's still, yes,
Yeah,
yes.
still a major problem.
So other preventatives, of course, we have the Pap smear for cervical
Sure,
cancer.
absolutely.
Cancer. Is that a high rate of cancer, cervical cancer?
Yeah, so talking about screening. So the Pap smear, in fact, this is the first screening test established 1928, in fact. First,
Really?
absolutely. The
Well, I didn't
earliest
know that.
Papa Nicolau or Pap smear.
Right.
And again, for with every screening, we seeing great results, especially with cervical cancer. Once women get screened and then detected early and cured in more than 90%. Now, what we know is the leading cause of cervical cancer is what we call is persistent or infection by HPV. It's a virus called the human papillomavirus.
Yep.
The persistence of this infection, this HPV, is the main cause of having cervical cancer. This is the bad news. The good news is that we have now vaccine
That's right.
for HPV
Yep.
that could take care of 9 types of these viruses, kill off 9 types of these viruses. By doing that, you could prevent 90% of cervical
Wow.
cancer
90%.
by getting the vaccine. And for the last 15 years, as you know, Linda, that with the HPV vaccine, starting at a younger age, not only in girls, but in boys too,
Right, that's right.
at 12 to around 16, 17. So a hugely effective vaccine preventing by cervical cancer. Numbers of vaccination rates still low. Still low. I think it's around 40% or a little bit higher for girls and much lower for boys. But again, this is well proven effective vaccine to prevent cervical cancer and other type of cancers.
Yep, yep. And they've extended it. It used to be, when it first came out, it was, 13 to 16 or something, but now they've extended it into the 20s.
They did. They
Yeah,
did.
so that's good. too.
That the vaccine, HPV vaccine, does not prevent or about routine screening, which is from 21
That's
doing
right.
cytology, Pap smear every 3 years or so. So it doesn't replace.
Right,
This is in addition to.
right, that's
But
right.
the point is, a vaccine could prevent 90% of cancer.
Wow. Do you think there'll be more vaccines coming out for various other kind of cancers?
Absolutely, and we hope so. We hope so, no doubt. Medicine again changed really.
Yes.
Not only in cancer, but different types, in heart disease and other stuff. And every year, huge efforts by the research team and scientists to find new ways of screening, different treatment options, more effective for cancer.
Right.
Absolutely.
Right, right.
So always looking for a new way of screening. Talking about new way of screening now, we are looking in, as we know, the screening test that we have is mainly one screening tool for one specific cancer. The new technology is now doing one test that could detect many cancers at the same time by detecting different
Wow.
DNAs
Right.
in just one test. That would be great because it's going to be
Yes.
simple, convenient,
Yes.
detecting many cancers
Yes,
in the future, hopefully soon,
right.
and will make it more attractive to people
Sure,
to get screened.
Sure.
by just doing blood tests
And you do a blood test anyway once a year for your,
for anything.
for iron and for cholesterol and
Absolutely.
glucose, so
Absolutely.
it could just be right in there.
And I think some of the challenge with the screening, as you know, especially with for colonoscopy, and all those patient of yours would tell you, well, but the prep is just
Oh, yeah.
unbelievable.
The
So,
test isn't bad, but
the
the
test-
prep is bad.
True, and I think that's one of the challenges. But as I said, change is happening every year in
That's
medicine.
right, that's right.
Better screen is happening, better treatment options are occurring, people living longer, no
Yes,
doubt.
yes.
Absolutely, I can tell you, now comparing to 20 years ago, individual with lung cancer or ovarian cancer or breast cancer are living much longer with better treatment, with less toxicity of the treatment.
Yes,
Really, I mean, we see it now. I mean, we're talking about years.
yes, I know.
That wasn't available years ago.
Yes, it's awesome. It really,
Absolutely.
yeah,
Absolutely.
it's good. It's really good.
And it's really that going back into, I think part of the challenge is the overall, I think part of the population maybe don't know all the details of the results of the screening. And there's probably some missing. Maybe there is some need more better communication between individual who come for their screening routine, yearly visit with the providers.
Right,
Talk more specifically about
Right.
the test, each test, the results that we're seeing, the survival rate and the cure rate
right,
happening with the.
right.
I think part of it is missing in a way.
And I was going to tell you out there listening, if your provider doesn't ask once a year for a colonoscopy, or, well, you don't have a colonoscopy once a year, but if they're either 3 to 5 to 10 years, depending upon what they've found.
True. What test and what they found. True.
Right. But and if your provider isn't saying, have you had your mammogram, or have you had your pap smear, or did you check, your PSA, be sure you ask those
True.
questions,
Absolutely.
Us providers, and I'm not trying to make excuses, but we have 20 minutes to talk to somebody, and there's a lot to talk about in 20 minutes. So if your provider isn't asking those questions, be sure you ask them. I don't know of a provider that would be upset about that. They'd
Absolutely.
probably be grateful.
Absolutely not. And I repeat it to all my patients. I think you're your own best doctor. To
That's
be
right.
honest. Just
Absolutely.
be always proactive.
Yes.
Don't wait for the provider to talk about anything that you're concerned about.
That's right.
Or anything you read or you saw on TV
Mm-hmm.
about screening in cancer and prevention. Just keep asking. Don't wait for a phone call from your primary care office.
That's right.
You call them if you need to. I think
And we've got to be our own advocates.
absolutely.
We do. We just, we're,
Be your
It's
own
just-
doctor.
yep, you're right.
Yeah.
You're right. I'm my own doctor.
You have to.
I know, right? All right, we're gonna, do you have any other things to talk about for cancer prevention? I think we've pretty much
I think
handled
we
most of
covered
that.
the five main cancer that we talked about: colon, breast, prostate, cervical, and lung. I think. As you said, we are very hopeful. Always being optimistic about new screening tests coming in soon for other type of cancer. Because I want to just remind that we have much more different type of cancer that less common, fortunately,
Right.
but to that we cannot screen because there is no screening tools yet available. But hopefully will come soon. And this with the new technology that one test could detect many cancer at the same time, that would be very helpful, really, in the near future.
Yeah,
hopefully.
that's
That would be
exciting
great.
to me.
Absolutely.
I'm all for that. I'm ready for that. I'm ready to
Seriously.
order that test.
And then everyone will get it, I think at one point, to be honest, medicine is changing. Medicine is becoming precision medicine,
Right,
focusing on specific things.
yes.
In cancer especially, and I'm sure in different diseases, is what's really causing cancer and find out what's causing the cancer. Because at this point, we can say is smoking is a big risk factor.
Yep.
But what we don't know exactly is what's the real genetic problem or mutation that's occurring that's causing cancer.
And both of my parents smoked like steam engines.
Yeah.
And they both smoked unfiltered Camels.
Yeah.
And neither one of them died of cancer. However, my dad had COPD, which ultimately caused, a heart attack, and that's what took him. And in his early 70s, and my mother had dementia.
Yeah.
And I'm just wondering which little wild cancer cell went in that brain of hers. I don't know. I don't know that there's any proof of that, but smoking is just one of the most horrible.
True. I mean, you mentioned that both parents smoked, but they didn't die from cancer.
Right.
But again, for the viewers, just to clarify that point, so if you take 100 people with new lung cancer, the majority, I'm talking about more than 80%, did smoke for many years. So the smoking still remain really the
problem.
The big risk factor.
Yeah. All right, it's time for our second break, and so when we come back, I don't know what we're going to talk about. I think we'll talk about the cancer programs and services at UNC Nash, because they've got, in my view, a top-notch cancer center. They can take care of you just like you can be taken care of at Chapel Hill or Greenville or Duke, any of those places. That can happen right here in our own backyard. So
Absolutely.
we'll probably talk about that when we come back.
Ma'am, sure.
Don't go away. We'll be right back.
When Jay arrived at the emergency department with a hernia, he was in pain, scared, and unsure of what would happen next. That's when he met Dr. Clarice Monnier.
The way she conveyed, it was something that I could understand. She didn't talk over my head. She called me at home on her cell phone just to see how I was doing. They really treated me like family. I just can't say enough, and I wouldn't be hesitant to come back here.
Learn more at nashsurgery.com.
We're in our 18th year of practice at the Hammer Chiropractic Center, and we've seen over 15,000 different people in the Rocky Mount area. 40% of headaches actually come from a neck problem. Many patients come in taking multiple aspirin, over-the-counter medications and such a day, and we can get you to stop doing that and actually fix the problem so the headaches don't arise anymore. A lot of people think chiropractic hurts. It does not. Most of the people come in and they feel great when they leave.
When faced with special care needs for elderly or disabled loved ones, families want compassionate, comforting care. That's Tender Touch Home Care Services' goal, providing the level of care we would expect for our own. With over 10 years of home care excellence, Tender Touch provides an array of services that keeps your loved one at home. From personal care, light housekeeping, errands, and meal preparation, to our private duty care program, which combines all of our home care offerings in one package.
Tender Touch Home Care Services, where your needs are our concern.
Welcome back. Here we are. We have been talking all about cancer and primarily prevention, which is really the best way not to get cancer is to work at it, eat right, exercise, don't smoke, do any modifiable things that you can so you won't. And of course, sometimes it's just going to happen. It might be in your genes, it might be in your DNA, but we talked a lot about prevention. And I really want to focus on the programs and services at UNC Nash.
Yes, absolutely.
Because in my view, they're top-notch.
I think, in my view, too, they're top-notch. And it's really the Cancer Center, Danny Talbot Cancer Center at UNC Nash is very well, solidly established cancer program. I have been there for more than 10 years. The radiation oncology has been there for 20 years. We have, as I said, 6 providers team of medical oncology. We have 2 radiation oncologists, We have a pharmacy team at the cancer center. We have financial team. We have patient navigator. We have palliative care clinic. We have a genetic clinic.
I didn't know you had a palliative care
We do.
clinic.
We started
I'm
that.
all about palliative care now, yeah.
True. And when I say palliative care, we're not talking about end of life.
No, of course
we're
not.
talking about the day of diagnosis
Right,
through the treatment.
right,
A patient could be cured or
Yes.
not, but during that period,
yes,
the focus of the palliative care is taking care of any symptoms or side effect that the patient could suffer,
Right, right.
either from the disease or from the treatment itself. So, as I said, financial support. We have nurse navigator. We have even hospice care for a terminal patient, and a social worker. Very solid team. Have been there since the
Yes,
start.
yes.
Very compassionate, take care of the patient. And these patients, as you know, with cancer, it's a journey. It's not one day treatment and they go back home. It's a journey through the treatment. A lot of them are cured. Some of them will die with the cancer. During that journey, we have a team of really individual taking care of them.
Right, right.
At all level of concern or challenges. The cancer center at the Nash is a separate building attached to the hospital.
That's right.
And at Nash, as you know, over the last 10 years, at UNC Nash, the improvement couldn't go unnoticed. We have a new women's center established in 2016, a new heart center in 2014. We had the expansion of the cancer center 2017 too, and the new ER that's really all revamped. And so going back to the cancer program we have,
Yeah.
really very strong in many ways, supported by different specialists. As I said, we have breast surgical team.
Right, right.
We have
How many surgeons are there?
Four.
Four,
Four.
okay.
Now, as you know, UNC Nash is affiliated, cooperates strongly with the UNC
Chapel Hill.
Health System in Chapel Hill. This is great cooperation. Why? Some of the complex surgery, big surgery that is not available in Rocky Mount, we refer them to
Sure.
UNC
That's
Chapel
right.
Hill. Because of that relationship we have UNC Chapel Hill, the transition, the referral, it's an easy process.
Right.
I can tell you we can, if when I refer someone today for a brain surgery or a lung surgery or a complex surgery, they could see them within a week to 2 weeks.
That's
So,
unheard of.
seriously.
Yes, yes.
And so this is great. Not only is big surgery, some treatment that we don't have available, like bone marrow transplant, CAR T-cell therapy, that available in Chapel Hill. The team over there will take over and take care of the
Right.
patient. So it's win-win really
Right,
for the patient,
right.
the population in Nash County and Edgecombe County and the surrounding areas.
right.
For them to know that if there is treatment that's not available, we are able to take care
Right.
of them, refer them to the right place. Now, having said that, 90% or 95% even of all cancer patients who comes to us at Nash will be cared for here. We are
Right.
ready for them to
That's
take
right.
care
That's
of them.
right. Mhm.
95%. The other stuff is small percentage, treatment that we don't have available, then we refer them to Chapel Hill.
And then once they're,
Or Duke sometimes,
right,
just.
right.
Or ECU,
Right.
just.
And then once they receive the surgery, for
Yes.
instance, we use that as an example, and they're on the mend, then they can
Come back to us,
home.
absolutely.
And there's no place like home.
True.
That's the best.
So I think any patient, especially cancer patient, they don't want to drive an hour and a half every week or twice a week
For
or even every month to get treatment in Raleigh or other places.
That's right, that's right.
As long as they can do it here, as long as they trust our cancer program. And so the treatment is available for them. So basically, especially in cancer care is a local care. Patient, they don't want to go anywhere.
That's right.
Unless for treatment that's not available here.
Right, that's right.
And as I said, we are here for them. we can take care and treat 95% of all cancer type that come to us. The 5% we are able to refer them for that. So, and again, the mission of UNC Nash really is take care of the citizens of the community. That's what
right.
it is.
That's exactly
and
right.
getting excellent care locally without them having traveled somewhere else for their care. That's the whole idea.
Right, right. And you've got a fantastic volunteer group over there.
We have great volunteer group. You mentioned the support group that we have. You know, we have events on a yearly basis. We have an event coming in August at the cancer center for the patient and their family. The Nash Foundation, as you know, very supportive and a lot of financial support for some of our cancer patients. Who need that support.
That's right.
Through the foundation, through the hospital, basically. I think the cancer program, the leadership at Nash, very involved in staying in touch with the community, cancer patient otherwise. The leadership at Nash, very supportive for our cancer program. Seriously. We still hiring a lot of providers to come and join. So we could remain strong and take care of all these patients.
Yes. They have a lot of resources there. They have a lot of, education, support services. I think are awesome. I mean, there's just. I think I look at this list and I think nutrition, pharmacy, social workers, cancer care fund if they need. Some people probably need help just getting a ride back and forth.
They do.
To the hospital.
They do, and some of the help, as you said, transportation, support, pharmacy. We have great pharmacy team. In fact, I want to mention that because a lot of the medication, especially the oral medication for cancer therapy, sometimes lack of financial coverage. By the typical,
those drugs are expensive.
Very expensive. Through the typical insurance company, our staff are great finding support from different national societies who provide that financial coverage.
Right.
Extremely helpful. As you said, cancer therapy, cancer treatment, or any treatment, in fact, it's very expensive. People can't afford that.
That's right. And insurance is only going to pay a small amount. Limited amount. They're going to cap the amount that they're going to spend.
True.
So we need extra help someplace.
Absolutely, and really, I can tell you that burden is taken care of by our team. Seriously.
Yeah, I believe that. So I just want to focus a couple of minutes on hematology.
Absolutely.
Because hematology, for those who don't know, hematology is diseases of the blood. And yes, there are cancers of blood, but there are other diseases as well. So I just wanted to kind of focus on that, hit on that for a minute.
True.
So, well, how much of your practice is oncology versus hematology?
I would say maybe 60-70% oncology and 30% hematology. Now, both are different specialty, so both are different training. But usually, most of the program, the program I went to in Boston, they provide training for both specialty. So when I'm saying I did training in hematology and oncology, so I'm board certified in both oncology and hematology.
Right.
Hematologists are basically, as I said, physicians who take care of and manage blood disease. And blood disease, I'll give you an example, anemia. As you know, a lot of people have anemias. So this is one of the common disease that we take care of. Low platelet counts, low counts in general, blood clotting problem, some deficiency in some vitamin K, a bleeding problem, oozing problem. So anything related to blood. But the most common, as I said, low blood counts, anemia, bleeding problem, and clotting problem. So at UNC Nash, it's true that it's called UNC Cancer Center, but in fact, it's a cancer and blood disease center.
Right.
So we treat both.
Right.
And all the providers that we have, in fact, are trained in both disease, hematology and. Sometimes I understand that, people could get confused if they're referred to us for anemia. They get a little bit scared that they're going to a cancer center.
Cancer.
True.
Yeah.
But what we treat both. In fact.
Yeah. And it used to be because I worked at Nash before it was UNC Nash. I worked there for 23 years, actually, and I think I've been gone 14 years now.
Okay.
I retired there and went to family medical and became a nurse, and I'm a nurse practitioner.
Okay.
But it used to be when a patient had a hemoglobin of 8, you would transfuse. Now that's down to 7.
Yeah.
What was the guidelines for that? How did they determine that?
True. So the guideline changed. And it's not only about the number anymore. First, it depends on what's causing that number to drop. So what's causing the anemia? Is it iron deficiency? Is it kidney problem? Are they bleeding somewhere? Is it medication? So a lot, as you know, anemia is not a disease by itself.
Right.
It's a result of a disease.
Right.
Lack of B12, some blood disease could be cancer, in fact. So anemia could be sometimes due to some form of cancer. So first step is to find out what's causing the anemia. Second step, how to treat it. So if someone is iron deficient, you give them iron. If someone has B12 deficient, you give them B12.
Right.
If they have kidney problem, fix that.
Right.
As far as transfusion, usually now, 7 gram is the number. Now, 7 gram is a 40-year-old is different than 7 gram in 90-year-old.
Right.
So it depends on each patient.
I gotcha.
So 7 and 90 is low. You need to be.
Right.
But 7 gram per deciliter in a young 40, 50-year-old, then you have time to take care of the cause of the anemia without rush to transfuse.
Right. Okay. I was just being curious.
Yeah.
All right. Well, it's time to say goodbye. I can't. It's gone by fast.
True.
Yeah, we've had a good time. All right. We will see you next week with more of Here's to Your Good Health. And again, thank you so much.
Absolutely.
For coming.
Thanks for having me.
Great to have
Thanks
you
a lot.
here.
Appreciate it.
My audience has learned as much
And
as.
thanks for the viewer who joined us.
That's right. That's right. All right. We'll see you next week with more of Here's to Your Good Health. Good night.
Good night.